This is the webinar series from the Eye Foundation called Sight and Sound Bites. This bi-weekly webinar series highlights research at the University of Pittsburgh School of Medicine. Today's topic is one I personally find really interesting, and I appreciate the content of today's program. It's called Hearing Loss in Babies, What Parents and Grandparents Should Know. I'm Lawton Snyder, CEO of the Eye Foundation. The Eye Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned Departments of Ophthalmology and Otolaryngology at the University of Pittsburgh. The funds we provide from the Eye Foundation to support research are only made possible because of philanthropic support. We count on that support to help initiate a lot of the projects and research things that you may hear about today, and thank everybody for who has provided support in now and in the future. Our housekeeping rules for today, you may recognize Zoom. I think everybody's been on Zoom in this last year, but what you may be used to using on Zoom is the chat feature. For our webinar series, chat is disabled, but what we do ask you to do is feel free to ask questions at any time, and we encourage that by using the button at the bottom of the screen. As you float down, you'll see Q&A function. Click on that, and you can just type a question right in there. At the end of the program, when Dr. Chi's finished, I'll start reading those questions. We'll ask you to refrain from asking personal health questions that wouldn't be as of interest to the rest of the group, but we will be happy to forward any questions to appropriate people if you have them. If you want to send personal questions to Mr. Craig Smith, who is in your email that you received. You'll receive a survey on this program, and we ask that you please respond to that so we can try to provide you better content in the future. And you'll be added to our email list for future webinars. Today's speaker is Dr. David Chi. Very nice to have Dr. Chi with us. Dr. Chi is an associate professor in the Department of Otolaryngology. He's the clinical director in Division of Pediatric Otolaryngology at Children's Hospital Pittsburgh of UPMC. And again, we're glad to have Dr. Chi here to talk to us about hearing loss in babies, what parents and grandparents should know. Thank you, Dr. Chi, and welcome.
Oh, thank you. Thank you, Lonnie. Thank you to the Eye Foundation for allowing me to participate in this webinar. We look forward to sharing this next half an hour with you to highlight what's going on at Children's, as well as this topic of hearing loss in babies. This is the outline of the presentation. We'll review normal hearing. We'll understand the significance and causes of hearing loss, and why we detect infant hearing loss, and some innovations that are ongoing in regards to treatment and future research about hearing loss. So let's understand what normal hearing is first. Pretend we are sound, and this video will highlight this. As we are sound, we enter the ear canal. And sound will cause the tympanic membrane or the eardrum to vibrate. And in the middle ear, there are three important bones: the hammer, anvil, and stirrup, or the malleus, incus, and stapes bone. As the sound vibrations occur, it causes those three middle ear bones to vibrate. And that causes the displacement of fluid in the inner ear. In the inner ear, there are hair cells. There are 3 rows of outer hair cells and 1 row of inner hair cells. And then the fluid displacement causes this movement of this fluid. And then that causes the hair cells to move. Once the hair cells move, it then triggers an electrical impulse that's transmitted to the brain. This is a magnified view of the hair cells. Movement of the hair cells results in a depolarization of the cell and release of neurotransmitters that then results in stimulating the nerve endings. It is the loss of these hair cells that is thought to cause hearing loss. Well, did you know that hearing loss is the most frequent birth condition? When we look at various common conditions that are publicized or reported upon, hearing loss is actually the most common. It occurs in approximately 3 per 1,000 live births. This is far more frequent than other conditions such as Down syndrome, spina bifida, sickle cell anemia, or PKU. So what is the epidemiology of hearing loss in infants? Well, approximately 12,000 infants are born annually in the United States. That equates to roughly 35 babies per day. Of note, 90% of deaf genetic kids have hearing parents, so oftentimes the parents or grandparents aren't familiar with this condition. One important aspect of hearing loss is that it has a big impact on development. This is a common chart that's often demonstrating the impact of hearing loss. This is the reading comprehension scores of those with hearing and deaf students. In yellow is highlighting the normal hearing children. It should be that in each year, there should be a 1 grade equivalent increase in a 1-to-1 ratio. In red is the reading comprehension scores of those with hearing loss. And one can see that slope is much decreased. It is not as steep and appropriate as the ones with normal hearing. This is a demonstration of a 10-year-old girl with severe hearing loss who was not detected until later on in life and was not treated. This audio clip demonstrates what her speech is like. One can see that without the context of the speech, that it is, or the descriptive writing, it's hard to understand what this child was trying to say. So there are benefits of early intervention. There's a classic study by Yoshinaga and Tano, which compared children who were diagnosed between birth and 6 months to those who were diagnosed after 6 months, and they received the same intervention. The conclusion was that those who were diagnosed by 6 months and treated by 6 months had better receptive, expressive language skills, and this was independent of age, gender, socioeconomic status, and ethnicity. So it's important to recognize that early detection and treatment of sensorineural hearing loss is vital. We view this as a neurodevelopmental emergency, and that early intervention has significant benefits. That is the impetus of the Universal Newborn Hearing Screening Program that we have in almost all the states, and as well as in Pennsylvania. The states have this mantra of 1-3-6. We want to screen by the first month of age, have a diagnosis by 3 months of age, and early intervention by 6 months. We even have new Joint Committee of Infant Hearing guidelines that challenges those states that are doing this well to lower it to 1-2-3. That is, screen by 1 month of age, diagnose by 2 months of age, and treat by 3 months of age when possible. So the question is, what causes hearing loss in children? Well, when we break down the etiology or causes, approximately 25% are thought to be acquired, about 25% are thought to be unknown, and about 50% are thought to be genetic. When we break down the genetic causes, a third of them are thought to be syndromic, and there are more than 500 syndromes that have been identified. It is beyond the scope of this talk to discuss all these syndromes, but want to emphasize that most genetic causes are non-syndromic. When we break down the non-syndromic causes, there are various inheritance patterns, and the two most common are autosomal recessive in approximately 60 to 80% of cases, and autosomal dominant in 15 to 20%. There's a smaller percentage that may be X-linked or mitochondrial. We'll focus for the purpose of this talk on the autosomal dominant and recessive causes. When we look at autosomal dominant, this is a quick review of the inheritance patterns that we understood from grade school genetics classes. Usually one parent has a hearing loss, and the parent will have 50% risk of transmitting the hearing loss gene to their child. Hearing loss with autosomal dominant causes are in general milder and usually starts in the second and third decades of life. This usually allows for normal speech development. Autosomal recessive causes require inheritance from each parent. Parent does not have hearing loss because they themselves are carriers, and about a quarter of their offspring will be affected because it is an autosomal recessive inheritance pattern. I want to focus on one autosomal recessive cause called Connexin 26. It is DFMB1, which is mapped to chromosome 13. It is the mutation of this gene named GJB2, which encodes a protein called Connexin. Of note, mutations of this specific gene is thought to be associated with 50% of autosomal recessive hearing loss, and the carrier rate in the Midwest United States is 2.5%. That is, if we had 100 people on the Zoom conference, the statistics support that 2 to 3 of us will probably have this gene that's associated with autosomal recessive hearing loss. So what is Connexin? Well, Connexin is a transmembrane gap junction protein, and 6 of these Connexin molecules forms a connexon. The best way to view this is view it as a docking station for cells, where 2 cells can join to communicate and then share the electrolytes, secondary messengers, and metabolites between these cells. There's various connexin proteins throughout the inner ear structures, and mutations in this gene lead to cellular dysfunction and deafness. I also want to discuss acquired hearing loss, which again is about 25% of the causes of hearing loss in infants. There's various acquired causes, including infection, ototoxins, prematurity, kernicterus or severe jaundice, and birth anoxia. I'd like to highlight the 2 of them, namely prematurity. This is thought to be the most significant perinatal factor for hearing loss. There is a 20-fold increase in sensorineural hearing loss in those with prematurity, and 5% of NICU graduates will have sensorineural hearing loss. There are apparent risk factors for hearing loss, such as anoxia, low birth weight, acidosis, hyperbilirubinemia, certain medications that are thought to be ototoxic, and meningitis. The other cause of acquired hearing loss is infections, and I want to focus on Cytomegalovirus or CMV. CMV is another nasty virus that starts with C and no one wants. Aesthetically, it looks beautiful. It looks like an ornament, but pathologically, it's up to no good. It's in the family of herpes virus and accounts for $4 billion per year in medical expenditure to treat CMV. From postnatal infections, the consequences of CMV are very limited, and infections are usually asymptomatic. If we get CMV, we usually do well. We have some cold-like symptoms. In the United States, the adult prevalence is about 50%, but in low and middle income countries, it is up to 90% by 3 years of age. CMV is transmitted by bodily fluids such as breast milk, saliva, urine, bodily fluids, blood transfusions, or organ transplant. And cute but draining children are the major sources for transmission. Unlike postnatal or acquired CMV, congenital CMV has many significant consequences. It is thought to be associated with 0.5 to 1% of all newborns, and 30,000 congenital CMV infections occur per year. It's thought to be associated with 140 deaths and over 5,500 children with permanent sequela from the CMV. So how is CMV transmitted to the mother to the baby? There are 2 ways. First is when a mother who has never had CMV develops an infection during pregnancy. This is considered a primary CMV infection, and there is approximately 30 to 40% risk of transmission in this fashion. The other way is a secondary infection. This occurs when a mom who has never had CMV or who has had CMV but then has a reactivation of a latent virus or reinfection with a new strain. This is thought to be associated with a 2% risk of transmitting the virus to the baby. Because of COVID-19, we've become very accustomed to hearing the terms symptomatic and asymptomatic. This also is true for CMV. Symptomatic infections occur in less than 10% of infections, and asymptomatic infections occur in approximately 90-95% of neonatal or congenital CMV. Symptomatic can be very broad in terms of spectrum of manifestations, from mild hearing loss to a stillbirth. I'd like to highlight some of these symptomatic congenital infections. These may be associated with prematurity or other features such as a large liver or spleen, low platelet, jaundice, microcephaly, chorioretinitis. The main aspect to highlight about symptomatic congenital infections is that it is associated with 50% of the time sensorineural hearing loss. This newborn was recently seen in our clinic with bilateral profound sensorineural hearing loss and microcephaly. He was positive for CMV. Asymptomatics are again much more common and insidious, but in these infants it is associated with 5 to 15% risk of sensorineural hearing loss. This can be present at birth or appear later, usually by age 5 years. The challenge is that there is no predictable method to know which children will get the hearing loss. People ask, what is the hearing loss with CMV? Well, it is thought to be the most common cause of non-hereditary sensorineural hearing loss, and about 20 to 25% of early childhood hearing loss is thought to be associated with CMV. Onset is usually between birth and 5 years, and there's a full spectrum of different manifestations of hearing loss, including unilateral or bilateral and mild to profound. So how do we diagnose CMV? Well, congenital CMV requires lab testing within the first 3 weeks of life. If it's tested after 3 weeks, it is uncertain if the infection was acquired postnatally. So it has to be tested within that first 3 weeks. Urine culture is the gold standard, but nowadays we offer saliva or urine PCR as an easier way to obtain the test. Many children present to clinic older than 3 weeks of age. So what are our options to check for CMV if they're older than 3 weeks? Well, we offer a testing from the dry blood spot or the Guthrie card that every infant gets when they are born. States vary in duration of keeping the card. In our state of Pennsylvania, we keep it for 12 months. Some keep it for many years, some keep it for only 3 months, but in Pennsylvania, it's 12 months. The issue with the dry blood spot card testing is that while the specificity is great, 99%, the sensitivity is fairly low at 35 to 85%. So in other words, if the test is positive, then it confirms CMV. If the test is negative, then we do not exclude CMV. So what happens to hearing when you treat for congenital CMV? One exciting aspect of this is that is this now a treatable cause of hearing loss? And this is the data. There's been some excellent papers that highlight the impact of treatment of CMV for the impact on hearing loss. And this is a study that looked at 42 symptomatic CMV patients. And half of them got Valganciclovir, which is the treatment for CMV, and others were the controls. At 6 months, no patient with Valganciclovir had worsened hearing, and approximately 40% of the controlled had worsened hearing. At 12 months, 20% of the treated group had worsened hearing, while 60% of the controls had worsened hearing. This study demonstrated that treatment with Valganciclovir prevented hearing deterioration in symptomatic CMV infants. Well, the question then was, if 6 weeks is good, what about 6 months of treatment? Would that be even better? Well, this paper from the New England Journal of Medicine looked at 96 patients with symptomatic CMV, and they were given either 6 weeks or 6 months of the antiviral Valganciclovir. They received follow-up for 6 months, 12 months, and 24 months. At 6 months, there was no significant difference. At 12 months, there were higher rates of normal or improved hearing in the 6 months group at 73% or 57%. And at 24 months, this was sustained. This study highlights that the use of 6 months of treatment is better than the 6 weeks of treatment. So the current evidence of treatment is only strong for those who are symptomatic newborns at less than 4 weeks of age diagnosis. It's unclear for beyond 4 weeks if there is isolated hearing loss or if the baby is completely asymptomatic with the CMV infection. All this prior work was for those who had major symptoms of CMV. There now remains a question about what the treatment is if the hearing loss is the only presentation of CMV. The Children's Hospital of Pittsburgh is one of the sites for the NIH Valganciclovir study that is conducted from Albert Park from Utah. We are randomizing patients with CMV and hearing loss only. They will receive Valganciclovir or placebo, and they're monitored for their hearing outcomes. We are excited to be part of this trial and hope to have information about a potential treatable cause of hearing loss. So what are the treatment options for inner ear hearing loss? Well, the mainstay is hearing aids, and that depends on the degree of hearing loss. As we all know, hearing loss may range from mild to profound, and this audio clip highlights what it's like to hear with severe hearing loss.
Timmy drew pictures of new toys on cards and showed them to Sally.
That, as you can imagine, will be hard to understand if you continually heard in that type of format for conversations or for schooling. This audio shows what the normal hearing is.
Timmy drew pictures of new toys on cards and showed them to Sally.
So hearing aids are the primary option. However, once the hearing loss is severe to profound, children may not benefit from hearing aids alone. Hearing aids amplify sound. For a person with severe to profound loss, hearing aid doesn't provide sufficient clarity or understanding of speech. Cochlear implants are used in cases when sensorineural hearing loss is so extensive that the mechanical amplification is not sufficient. The cochlear implant, therefore, is very different from a conventional hearing aid as it bypasses the function of the external and middle ear, and then it stimulates the inner ear nerve endings that are present in the cochlea. This video clip demonstrates This video clip demonstrates how a cochlear implant works. Sound is received from the ear, and there's a microphone at the level of the ear. The microphone then sends it to the sound processor, which digitizes it and converts it to a signal that's transmitted through the skin, usually via radio frequency, to the surgically implanted cochlear implant. The implant then delivers the electrical signals to the surgically placed electrodes, which then stimulates the inner ear nerve endings, and then the brain then can receive this as sound. So who are the candidates for a cochlear implant? Well, the selection criteria for kids now is as early as 9 months, and they must have no benefit or minimal benefit from hearing aids. There must be no medical reasons that prevent surgery. And there should be high motivation, realistic expectations from the parents. At Children's Hospital of Pittsburgh, we have a comprehensive team approach to assess for candidacy. We meet monthly around a table, usually with bagels, to discuss every child thoroughly before moving forward with a cochlear implant. Children get assessed by each of these specialties before we make a decision about what the best options are for our children. A lot of families have questions about cochlear implants. First, they ask, can we only get one implant? If you're a candidate for one, then can you have the other ear implanted? The answer is yes. We recognize the importance of hearing with 2 ears, and we support implanting with both ears when appropriate. People also ask, what if there is residual hearing? Can my child or grandchild get a cochlear implant? The answer is yes. If a cochlear implant provides greater access to sounds than what a hearing aid gives, then they may be a candidate. Of note, surgery and implants have been advanced so that cochlear implants may preserve the residual hearing. Children's Hospital recently published in the medical literature data that supports that in kids, we can preserve hearing in children in those ears with residual hearing approximately 70% of the cases. What if the other ear is normal and there is hearing loss in only 1 ear? Can these children be implanted? The answer again is yes. Data supports that if you have 1 ear hearing loss, then motivated families may move forward with cochlear implants so that they may benefit with 2-ear hearing. People ask, what is it like to hear with a cochlear implant? Well, for those who have hearing that lost it and then subsequently got a cochlear implant, they describe it as saying it sounds initially robotic or mechanical. This audio clip demonstrates what it's like to hear with a cochlear implant.
This is an example of an 8-channel processor. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Over time, the sound perception is thought to be very natural and that they are not bothered by those sounds, and it sounds more natural to them. So what are some innovative research at Children's Hospital Pittsburgh? Well, we're conducting some quality of life studies for children with cochlear implants. We like to know what the impact is, not just on the medical side, but also on the quality of life. We're also collaborating with Carnegie Mellon University Robotics and to describe how we can potentially convert robotics for mastoid surgery. This video clip demonstrates how a surgeon's hands can be mimicked by the movement of the robot. He is carving his name in the wood block with the Dremel drill that's attached to the robot. Afterwards, it memorizes what the steps of the surgeon was so that it can execute the function by itself. The idea behind this is that if there is an opportunity to have a surgeon operate on a 3D printed model first, and then the robot can execute it safely on the patient. Therefore, there will be increased safety, increased efficiency of the robot compared to drilling the first time on an actual patient. Lastly, I'd like to close with a video that kind of highlights how it brings it to real life, how it makes it real, what an activation of a cochlear implant is for a family, for a child who's never heard, and finally the cochlear implant's activated. This is a boy that was implanted bilaterally, and this is his initial activation session. He has not heard before, but this is what it was, his response.
Look, buddy. Definitely look around. And I think, nope, came back on. We'll start and stay at that level because you definitely peaked up there.
So in conclusion, I want to highlight the importance of infant hearing loss and the importance of early identification. Genetics is the most common cause of hearing loss in infants, and that we should consider CMV whenever there is a suspected hearing loss. The treatment options are excellent for children with hearing loss, and we're excited to participate in research that continues to advance this field. I want to thank you for your attention.
Wow. You know, Dr. Chi, it's such a pleasure to have you do this for us today. And I've probably seen videos like that maybe a dozen times. And my wife's an audiologist, so I actually got to sit in a room one time when that cochlear implant was turned on. It just gives me the same response every time, how wonderful it is to see hearing for the first time and how it impacts us. So thank you for sharing that. And again, this whole program, the importance of hearing for children as they develop and as they grow and as they're learning speech and as they're learning, you know, their world and their environment, that stimulus is so critically important. And you're providing that to so many. So thank you.
Oh, thanks, Lonnie. I think it's truly a privilege for us to have this impact. in children, and to partner with the Ear Foundation for the support of research and all the efforts. We appreciate that.
Well, it's it's certainly impressive. I'll start with a question. I see we already have a bunch coming in, but I'm going to ask you because I was thinking about it as you mentioned, and I never thought about people who have hearing loss, profound hearing loss in one ear, and normal hearing or sufficient hearing in the other ear, and you said you can do cochlear implant. Is it difficult for the patient to discern between the digital sound and then the actual sound? Is that a challenge for patients?
So Lai, that's a great question. I think that was one of the reasons where there was some hesitation about implanting for one ear. That is that one side they will hear acoustically, the other side they will hear electrically with a cochlear implant. There was some concerns about putting a child or an adult who had that one side of normal hearing. But interestingly, the data supports that they do well. They assimilate that well. And that gives them the opportunity not to hear with just one ear, but they are hearing them with two ears.
Well, again, it's incredible. It's incredible how adaptive people are. So here I'm going to get to our viewers' questions, and thank you for submitting them here. We got first, how do different parts of the country measure up relative to infant hearing loss, i.e. are rural areas having a hard time keeping up with current standards?
So that's a very good point. The challenge is that the screening does work well. Even in rural facilities, they do the screen. They are able to do it in the birthing facilities. However, the follow-up and diagnosis may be more difficult if they are in an area where they don't have the easy access to an audiologist. So even though they may be known to not pass a newborn screen, it is a little bit added challenge for these families to make it to a facility that is able to do the testing and diagnosis.
Are there solutions down the road for those situations, those who are in more rural communities?
Yeah, I think this is true for hearing loss, for any other conditions, is the issue of access to care. And for this, we try to give them all the information to tell them the importance of early follow-up, the importance of making sure that they have appointments, to make sure that they get their opportunity to have transportation to get to the testing facilities. Screening, again, is done well, but the confirmation diagnosis needs to be done on a more consistent basis.
So does a failure of a newborn hearing screening mean certain hearing loss?
It does not specify what type of hearing loss. It could be from simple things, just fluid in the ear, from the amniotic fluid. It could be just from a noisy environment that the testing occurred that prevented the screen pass. And that does not imply if it's conductive hearing loss or sensorineural hearing loss. We don't ever want to just assume that it is just the fluid alone or just a testing environment that caused the non-pass. It's so important to emphasize and get the word out that there is the follow-up to make sure that there is some confirmation of hearing loss or absence of hearing loss from the screening test.
Can a mother know whether she contracts CMV? What are the symptoms?
So that is the real challenge because CMV can be very insidious, and a mom may not know that she has had CMV. There are some immunoglobulin testing that one can do to see if they have had prior exposure to CMV, but it does not mean that they are immune from transmitting the CMV to their baby because there are secondary infections that may occur. Symptoms, again, can be very minimal, asymptomatic from when a mom has CMV. With that in mind, a lot of states are now moving forward to screen for CMV in the baby if the baby did not pass their newborn hearing screen. The state of Pennsylvania has some legislation that's proposed, and I've been working with the state for that as well. But there is some legislation that's suggested to move forward. States are moving in that direction to require that CMV testing if you did not pass your newborn hearing screen to check for if this was from CMV alone.
Is CMV transmission an issue for daycare centers? As your example displayed, a child with excessive mucus. And by the way, every parent has seen that
Yeah.
at one point or another.
I think that is so true for all the parents, grandparents. We all seen that type of picture in our family members. It is a concern, and therefore, just like from COVID, we've emphasized hygiene, we emphasized hand washing. There is a additional concern with the secretions being transmitted from most likely from siblings to home. So there is that wonder to make sure that there is the appropriate hygiene. Hand washing, hand sanitizing, that will be important to minimize that transmission of CMV.
So how can grandparents, along with aunts and uncles, help with identifying hearing loss and deficiency?
So I think when it's an infant, it's actually challenging because we don't get the response of a newborn once there is a suspected hearing loss. That's why there is such an important aspect of having the newborn hearing screen that should be done on all our infants. The other aspect is later on in school life. As they're going on, hearing loss can occur later. So there should be just an emphasis of just seeing how they communicate, see how they are interacting, see how their school performance is. Don't ever assume that the speech and language concerns may be just developmental issues, but to make sure that hearing is evaluated and have a low threshold to have hearing checked if there is a concern of hearing.
Along those lines, is it common for parents to maybe deny symptoms of hearing loss in their children that they may see? And is that a way that parents, grandparents otherwise can be a little more proactive?
Yeah, I think as parents, sometimes we see it day in, day out, and as grandparents or extended family members who don't see the day in, day out changes, that they can be more noticing if there is some speech developmental concerns, interaction concerns, and to make sure that to have a appropriate discussion with the parents, the family, to see if testing can be done. This is just a screening test, and we always emphasize having a low threshold to move forward with testing if there is any speech or hearing concerns.
So with increase in home births, is there a concern about lack of screening?
Yes, so in the state of Pennsylvania, they've actually studied this. They actually look at the in-home births because, as you can imagine, midwives or so may not have the equipment to test as well. So the state in the past have provided the midwives with this equipment. We want to continue to increase the testing of the babies born at midwife facilities so that there will be the appropriate documentation. And they've been doing a fairly good job. This is a continuous work in progress to make sure that the out-of-hospital birth testing is maintained and is sustained in a good fashion, especially in the state of Pennsylvania that we're working at. This is a
Very
struggle
good.
across the state, across the country, because some other states may not have the additional resources to provide to these midwives. It emphasizes the importance of education to the midwives to make sure that if they're born with a midwife facility, that they go to a testing facility for screening.
Well, thank you again. That's the end of the questions here, but certainly please quickly type in a question if you have any more. We do have more time. I'll follow up with something just myself. When as you mentioned that there is screening in schools as well, and that's an important aspect because we can see hearing loss later on in children. And is there more that can be done in a classroom setting to make sure that children are hearing in terms of their, really benefiting of education? Is there more that can be done from the standpoint of teachers in classrooms or from the standpoint of, again, assessment and evaluation of those who may be struggling with their hearing?
Yeah, so there's various strategies that a school can employ for a child who may have had a diagnosis of hearing loss. Simple measures include having a preferential seating to make sure they're closer to the front of the room. School districts often have resources such as an FM system in which the teacher speaks into a microphone And there's various speakers that can be set all throughout the room, whether it's at the child's desk, teacher's desk, or even within the AV system of the classroom, so that it actually increases the signal, the teacher's voice, relative to the background noise, the cooling duct system, the other children, to minimize that and to increase that signal to noise ratio. So those are some good strategies that can be done. The latest generation hearing aids can be easily coupled to these FM systems, so that they will be having good access to the FM system, teacher's microphone, to their hearing aids directly. So these are some strategies that can be done through the school. The school can also look at noise dampening, if there's a benefit from having more of a carpeting or a rug, or some of the curtains that may be more absorbing of the sounds in the environment, to make it acoustically a better area for the child.
And while we were discussing this, we got a few more questions that came in. So can you please also discuss the extent of or the impact of hearing loss on balance?
That's a great question that is still being investigated. There are some conditions that may be associated with balance, and there's some genetic conditions that can also be associated with balance. This is the Eye, Ear, and Ear Foundation, so we know that there are some visual conditions and syndromes, such as Usher syndrome, that can be associated with hearing loss, as well as some balance disruption. And so these are all important. The ear is intimately associated with hearing and balance. So at times, if there's a concern of hearing, but also a balance disruption, these children can be evaluated for their balance as well.
Is there a stigma around children wearing hearing aids, like those wearing glasses? And do children adapt to those easier?
Yeah, I think perhaps we as parents, grandparents, or extended families wonder about the stigma. But as a child, especially if they're fitted early, especially as an infant or in their first years of life, it seems like they adapt to it, they accept them as their own, and that there's less and less of a stigma of wearing hearing aids. I try to view it positively. Some of us wear glasses to see better. Some people will wear hearing aids to hear better. Nowadays, it seems like there's more of a fashion element of wearing something on our ears, whether it's AirPods or Bluetooth phone adapters. And so if the child is well adjusted, they accept that well, especially when they're received it early in childhood.
And there's a follow-up question from our discussion around the schools. On that note, does Pittsburgh Public Schools have an access to care program in place to help patients that they identify that might have hearing issues but low resources?
Yeah, Pittsburgh Public Schools does have resources for a child, a student who has hearing loss. And one of the bright things about the Hearing Center at Pittsburgh is that we actually have an educational liaison, Jessica Lampert, who's joined our team and has been a great contact for the families and the schools to make sure that they are fully aware about the resources. But Pittsburgh Public Schools does have a lot of good resources for their children.
Well, following up on that, of course, hearing aids are very expensive, certainly for adults, and we all know that. And if you have to, but for children, are there resources through the state?
Yeah, and that's a very important point, Lonnie. In the state of Pennsylvania, based on a diagnosis of hearing loss, the family and the child qualifies for medical assistance, and they help to provide the hearing aids for those who are diagnosed with sensorineural hearing loss, regardless of the means. So it is a great advantage to qualify for medical assistance through the state, so that it will help to offset the cost of hearing aids. As we know, the hearing aids are not covered with adult insurance products. And so it is something that we, for children, have a great resource and opportunity to obtain.
Wonderful. Another question, what kind of quality of life research studies are being conducted?
Yeah, so the way we're conducting these QOL studies are survey-based, and to ask them, and these are a new opportunity that we have to just follow up on the implanted kids. We're arranging that now, and to have it so that they could be monitored after they get a cochlear implant, after they've been diagnosed with hearing loss, to see how their quality of life is measured throughout their time that they are with a cochlear implant.
So is cochlear implant surgery covered by medical assistance?
It is covered by insurance and is not deemed as a out-of-pocket expenditure. We all obviously go through the insurance approval mechanism, but if there is appropriate indications following all the appropriate guidelines, it is a covered surgical procedure.
And that's the same for adults as well, am I right?
Correct.
Okay. Well, Dr. Chi, thank you. Again, wonderful topic. You covered it incredibly well, and very important, I think, for people to know. And again, how important hearing is in all aspects of life, particularly for young people as they're growing and learning and developing and learning skills and learning languages. So thank you for sharing this with us today. It looks like there are no more questions. So we will, oh, wait a minute, hold on. Oh, it's just a thank you. Appreciating your presentation, thank you. So thank you all for coming, and we will look forward to doing another program in a couple weeks and sharing this with you. And again, this program is recorded, and we will be putting the recording on our website, www.ienear.org. You'll also receive an email from our office that will have a link to the recording. If you want to share it with any family members, friends, people that could not attend today. And one last question. So are there any complications with cochlear implants? That's a good question. We'll end with that.
Sure. So like all surgeries, there are complications, and God put some important anatomy right near our ear. And so it does require some care to do the surgery. Like all things, it's a device. So there's a chance for a device to fail. Device can malfunction. Thankfully, they can be replaced. There are some important nerves and vessels near our ear that the surgeon has to be very careful to avoid. There's also the brain that's not far from the ear, so that we also have to avoid the spaces that are separating the ear from the intracranial spaces. So there are complications, and like all surgeries, and it does require the care of appropriate surgical placement.
It's a complicated surgery, and I do know this because we have in our building on the first floor a surgical training lab that teaches our surgeons that our surgeons can practice on these very complicated procedures, as you saw from Dr. Chi's demonstration of going through, bone and avoiding those critical measures. It requires a lot of training, very good hands, very good surgeons. So that's ultimately what I think people need to know is that you definitely want to see, a good surgeon who's done this before. So, Dr. Chi, thank you so much. All right, we'll see everybody again in a couple weeks. Look for invitations to our program, and Dr. Chi, it would be good to see you around.
All right, thank you, everyone.